Our topic today is related to vascular trauma and a discussion of what it will take to equip and prepare tomorrow's workforce to deal with this injury subset. Now, I wanted to spend a moment to say that the point of this grand rounds is not to say who can do it better, trauma surgeons or vascular surgeons. People will continue to discuss that after we are done here. Rather, the premise of this grand rounds is to be more practical, to introduce a fresh concepts, and to be more solution-oriented. We wanted to frame this ongoing story a bit differently. Now, without further ado, our agenda for this evening includes an introduction of our speakers by my co-moderator, Dr. Alex Schwed. Dr. Kundi will discuss the evolution of vascular trauma as we know it and pitfalls in coverage. Dr. Savage will explain the current training structure and potential solutions. Dr. Brenner will go over strategies young faculty can utilize to maintain and acquire vascular skills. And finally, Dr. Scalea will discuss the shock trauma model and how it is employed to deliver care. This will be followed by a discussion in BOSS conference style, which will be introduced later.
Good afternoon, everyone. It's my pleasure to welcome our panelists to the discussion. Dr. Rishi Kundi is an associate professor of surgery at the R. Adams Cowley Shock Trauma Center. He's also the chief of endovascular trauma surgery and the director of the GO team. Dr. Stephanie Savage has actually stepped away. She's responding to a trauma, but hopefully she'll be joining us shortly. She is the professor of surgery, the director of emergency general surgery at the University of Wisconsin, as well as the medical director of the Emergency General Surgery Service and the chair of the Acute Care Surgery Committee of the AAST. Dr. Megan Brenner is a professor of surgery at the David Geffen School of Medicine at UCLA in Los Angeles. She is the creator and director of the American College of Surgeons Committee on Trauma BEST course. And finally, a man who I think needs no introduction, Dr. Thomas Scalea is the Francis Eck Kelly Distinguished Professor of Trauma and the Director of Program in Trauma at the University of Maryland School of Medicine. He's also the physician-in-chief of the R. Adams Cowley Shock Trauma Center and the Director of Critical Care Services at the University of Maryland Medical Center. Finally, just as a announcement from the AAST, which of note, the AAST no longer offers CME for live grand rounds. Should CME be available for the archived version of this grand rounds, those who watched it today will receive an email once the archived version is available on the AAST website, and it will prompt you to log in to be able to claim your credit. So with no further ado, I'll turn it back over to my co-moderator, Dr. Dhillon.
Thank you, Dr. Schwed. So we'll start off our discussion this evening with a talk by Dr. Kundi, who will be discussing the evolution of vascular trauma and pitfalls in vascular trauma coverage. Dr. Kundi.
Good afternoon. My name is Rishi Kundi, and I'm a trauma surgeon and a vascular surgeon at the Shock Trauma Center in Baltimore. Whenever I talk about vascular trauma, everyone in the audience assumes they know what I'm going to say and gets preemptively angry. So I'm going to give you the ending first so you keep listening. Effective trauma surgical care in the operating room relies on an understanding of three areas. The first is technical procedural aptitude. How well can you perform the anastomosis? All things being equal, a vascular surgeon is going to have way more experience with this than anyone else, but all things are absolutely not equal. The second is anatomical context. How familiar are you not with the rote script for an exposure, but with the territory itself? How good are you at improvising getting from point A to point B when the highway in between the two has been blown up? And that's the firmament of trauma surgery. And finally, disease physiology. Trauma is a disease, and experience with it is absolutely crucial to perioperative and intraoperative decision-making. Of course, that's going to go to trauma, and by a significant margin. Vascular surgeons have better technical aptitude than trauma surgeons, but they don't spend as much time around the disease physiology, and they're generally not as familiar with the anatomical context as trauma surgeons are. And these are important when taking care of the injured patient. And here's the main thrust of my talk. These differences are only going to get worse in the years to come, as a greater proportion of vascular surgeons are products of integrated vascular residencies and have almost no familiarity with disease physiology or anatomical context. I trained in general surgery, did a vascular fellowship, and came to the University of Maryland as faculty. I had a pretty typical junior academic practice. I liked teaching, which was probably because my first fellow was Megan Brenner. I was on track. According to the ABS, there are currently 84 vascular surgeons who are certified in general surgery and critical care, but there are less than a dozen who are active in trauma surgery. Among that group, I only know of 2 people, myself and Melanie Hain, who sought trauma training after being in vascular practice for a period. I did a general surgery residency because I wanted to be the doctor who would get picked to be on a mission to Mars, someone who could correct physiological derangements as well as fix anatomy. Over years of vascular surgical practice, that just came to describe me less. My patients would be admitted to the medicine service or subjected to unending consultations, and I just became the guy who sewed the anastomosis or put in the stent. I was becoming a technician. So I left my practice, went back to fellowship, and then I came here. In 2018, Ben Starnes at the University of Washington found that the rate of intraoperative vascular surgical consultation increased by more than 500% between 2002 and 2017. Not only were most of these intraoperative consults called by trauma surgery, but the increase in consultation was disproportionately due to trauma surgery, which accounted for 1,400% increase. The intuitive response is that the increase was attributable to endovascular procedures, but the proportion of consults that resulted in endo procedures wasn't substantial, and it didn't change over time. A few years later, Ravi Rajani at Emory looked at just lower extremity vascular injuries. In 2011, vascular surgeons weren't consulted for these once. 8 years later, they were involved in 70% of these cases. Rajani broadened his view and looked at all trauma. Slightly more than a quarter of all trauma patients who went to the OR within 3 hours of presentation resulted in some kind of intraoperative consultation. Most of the time, that was vascular. If they went to the OR within an hour, it was more likely that vascular was involved. Over the 5 years studied, only vascular surgery demonstrated a statistically significant increase in the rate of intraoperative consultation. These are the factors that predicted intraoperative vascular surgical consultation. Vascular surgery was being called for sicker patients. One more paper, I promise. This one is out of USC. The authors looked at vascular injuries managed by trauma surgeons and those by vascular surgeons, and they concluded that outcomes weren't different between the two. But the vascular surgeons were called far more often for injuries distal to the elbow or the knee, and for multiple vascular injuries, basically more technically challenging cases. Patients with hard sides of injury were more likely to go with trauma than vascular. A patient being hypotensive made them 3 times less likely to be taken care of by a vascular surgeon. And each incremental increase in ISS made it 7% less likely that a vascular surgeon would be called. As technical difficulty increased, vascular surgery was more likely to do the case. And as patient condition worsened, trauma was more likely to do the case. Now, every one of the papers I've mentioned thus far has discussed training and experience as factors contributing to this shift. Most of the data regarding training case volumes ends in the mid-2010s. Here's the problem with that. The first integrated vascular surgery residents started in 2007. That meant that they finished in 2012, and most of that case volume data barely included their numbers. This is important. The number of integrated vascular residencies is increasing every year. And in 10 years, when a trauma surgeon calls a vascular surgeon, they're going to be much more likely to reach someone who hasn't done any general surgery residency. So I looked at case data for 3 groups. First, the vascular surgery integrated resident classes from 2013 through 2022. Second, the gen surg residents also graduating that span of time. And finally, I looked at the total case experience from general surgery and vascular fellowship combined of vascular surgery fellows graduating between 2013 and 2022. When you look at open vascular case experience, the results aren't surprising. There is a substantial difference across the board between general surgery residents and either flavor of vascular surgery graduates. By the way, over the last 10 years, the general surgery resident experience has seen a decrease only in the numbers of complex open vascular surgery, by which I mean reoperation, graft explantation, and so on. Endovascular numbers have increased, but everything else has basically stayed about the same for them. So a vascular surgeon, even one from an integrated program, gets more technical experience doing vascular surgery. This is not surprising. But what about anatomic context? A below-knee POP exposure for an elective bypass is a straightforward scripted affair. But finding a transected popliteal and a mangled leg is a different beast altogether. So when I poked at this question, I found something really worrisome. Here are the integrated resident numbers over that period, comparing the vascular repair numbers to the vascular exposures. These are wildly discordant. Even if you assume that every XLAP or neck exploration that an integrated resident did corresponded with an arterial repair, they still repair vessels at anywhere from 2 to 5 times as often as they expose them. The ideas that Rajani and Starn sketched out are manifest in these trauma training numbers. For the integrated vascular surgical resident, the initial exposure and control are being done by someone else, and the repair or the anastomosis is increasingly being isolated as a technical procedure for the specialist to perform. Since they're not getting explicit exposure experience, I thought it worthwhile to compare overall experience by body region, not vascular, not trauma, just open experience. Familiarity not with procedural anatomy, but with the overall anatomical context. How familiar are they with the territory? I compared all non-trauma, non-vascular numbers between general surgery and integrated vascular surgery. I assumed that the difference between vascular fellowship graduates and general surgery graduates would be trivial. The results are clearly dramatic. So we know that when it comes to anatomical context, understanding, familiarity with the territory, which is the important thing in trauma, the integrated vascular trainee is far behind anyone who's finished general surgery residency. There's one area left, disease physiology. A brief story. A few months ago, Baltimore had a rough night and we had to run a half dozen rooms. We didn't have enough shock trauma anesthesia staff, so I found myself doing a subclavian repair with an anesthesiologist from the general side ORs. About 45 minutes in, I asked how much blood the patient had gotten. 6 liters of plasma was the reply. Our vascular surgeons want us to give blood only after the anastomoses are finished. So my last question was this: how much experience do our emerging vascular surgeons have at managing sick patients? Your integrated vascular surgery resident graduates having managed 5 patients ventilator settings, 4 hemodynamically unstable patients, and fewer than 2 trauma patients managed non-operatively. The black bars are general surgery and vascular surgery graduates. Nobody is saying the vascular surgeon should be managing polytrauma patients, but intraoperative decisions have to be based not only on the injury you got exposed or the anastomosis you're doing, but the condition of the patient around that exposure. I've thrown a lot of numbers at you all, and I am reasonably close to going over my time, so I'll summarize. Vascular surgeons are increasingly contributing to the care of the injured patient. That's just the fact. The trend is occurring in parallel with the rise of the integrated vascular surgery resident who has as much experience with vascular technique as the fellowship-trained vascular surgeon, but who has drastically less experience with anatomical context or taking care of sick patients. These two trends, unfortunately, have the combined effect of making the trauma surgeon less technically adept and the vascular surgeon a technician who doesn't understand his patient's disease at all. Now, I fought against becoming a technician by returning to training, and I think the solution to this has to be based in training. Give vascular trainees time on a trauma service at a point in their training where they're able to really learn, not just as a PGY2 pulling chest tubes. Have trauma surgeons get experience in vascular and endovascular surgery. We have outside rotators on our endovascular service here. Get the anastomotic reps the way that I did, not just by doing a pop bypass once a month, but by doing 6 AV fistulas a day. Things are changing, and they're changing to the detriment, I think, of both fields. The only way forward has to be both fundamental, how we build our surgeons, and together in collaboration, not competition. Thank you.
Thank you so much, Dr. Kundi. That was very thought-provoking. As a surgical educator myself, there's some notes that I was scribbling about how we're going to fix all the case log data to really analyze some of your claims. Dr. Savage is going to talk to us about the current training paradigm that AAST fellows are held to, and maybe some future directions for AAST fellowships, and perhaps can speak to some of the issues that Dr. Kundi raised as well.
Dr. Kundi, first of all, I'd like to thank you. That was an amazing talk. I love the bias that has, and you set me up perfectly for my portion of the talk. I don't know, Caitlin, if you have my slides or if you need me to share my extremely messy desktop. Let's take that as...
If you're able, Dr. Savage, to share your PowerPoint, I think that'd be great.
Let me try to share and get it on the screen so that I'm looking right at you guys. All right. And we're going to talk about the current training paradigm, identifying gaps in training and some potential solutions. This talk is somewhat aspirational as it's a direction that we're going to. We're not 100% there yet, but you'll kind of see where I'm heading in a minute. So it used to be that the general surgeon could operate in any part of the body, and the trauma surgeon was kind of like the general forces or the special forces of trauma surgery. We could do anything, anywhere. in the worst possible situations, bleeding, inflammation, complete disasters. That's our role. I feel like somewhat according to Dr. Kundi's talk, a little bit opposite in that I'm worried that we're becoming more of the traffic cops of trauma surgery, and that we spend a lot of time calling subspecialists to do some of the surgeries that we used to do ourselves. And I don't want to imply that it's not worthwhile to collaborate with your subspecialists, because it absolutely is. And they frequently have perspectives and techniques and experiences that we may not have or are learning. But I do worry that we give away a lot of cases that we really need to be facile with in order to take care of our patients. So you heard some of the fundamental issues from kind of the integrated perspective. And I think that, you know, when myself as a trauma surgeon or someone coming out of training thinks about their skill set and they want to perform vascular trauma, there are some things that you need to consider. You need to consider your local exposure and what your volume is for vascular trauma. I think if you're in a group that doesn't do their own vascular, it's really hard to show up and start doing it on your own. And also to consider the fact that the local politics may not support you in that. So you may be swimming upstream and trying to do these, even if you feel like you have the skill set to back you up. And certainly as a junior faculty coming out of your training, it's always good to have more senior backup if you have a question or you need a little bit of help. And if your group doesn't do that, you can kind of be left alone. So that's a little bit daunting. And then some of the management challenges that Dr. Kundi kind of referenced, which is that how we manage trauma patients is very different than how a vascular surgeon might manage a primarily vascular patient, and taking into consideration the entire physiology of the patient, the injury burden, and all of those things when you're making your intraoperative decisions is really important. And so keeping the trauma surgeon involved in the vascular part of the trauma is, I think, crucial. So what's the answer? Well, I queried our particular residency program here at University of Wisconsin and said, how much exposure do our general surgery residents have to vascular in their 5 to 7 years of training? And this is what they do. So they have somewhere around 4 to 5 blocks of vascular surgery during those 7 years. When they're really junior residents, of course, they're just mostly doing orders and taking care of the floor work, so they may not be obtaining those technical skills. And so it's really as a PGY 3 or 4 that they're getting the technical exposure, but they're competing with the vascular fellows, the integrated residents for the good cases. And so it's not as robust as it could be in terms of the skill set that you need going forward. If you opt to do the surgical critical care year, then your exposure to vascular cases depends somewhat on how often you take call and what comes in the door. If you do the acute care surgery year, however, we do have vascular case requirements to get you kind of set up to go forth and be an independent trauma surgeon taking care of these types of injuries. But freely admit, it's not huge numbers. These are relatively small numbers of all the key things that you need to make your decisions and get your exposures. But I wouldn't say that that's a super deep bench. This is supposed to be additive of really complicated things on top of the skill set that you obtained as a resident. But it'll get you started. And then down here, you can see some extra things that we would really like you to have exposure to, but they're not mandatory case requirements for the purposes of the fellowship. But hopefully the acute care surgery fellowship at a bare minimum will get you comfortable with knowing when to go to the OR, how to get control of the bleeding and expose the site per Dr. Kundi's talk earlier, maybe when you're going to shunt. Hopefully you'll be comfortable actually performing the technical aspects of the repair. And then also very importantly, how to do the post-operative management of these patients as well. Begs the question, is that enough? If you go through a general surgery residency and you do the acute care surgery fellowship, are you set to go and ready to be a vascular surgeon at a high volume center, a vascular trauma surgeon? If you're going to go into the military and you anticipate being deployed in a far forward setting where it's you, or you're at a place like shock trauma where you're going to be doing some of these things on your own, or your group does vascular trauma, is that going to set you up to be prepared to do this? And I think that answer is different for every person. But we've started to think about how we approach this problem of needing special expertise within the fellowship. And this is an example of subtracks that we've started to develop for the acute care surgery fellowship. This particular one is for pediatric surgery, but it is within 8 weeks of launching. And this is the template that we're using going forward to look at subtracks in different areas that you might be interested in if you're a trainee doing the acute care surgery fellowship. So you can see here that it is the certificate will be your acute care surgery fellowship with pediatric expertise. And importantly, it is supported and endorsed by the American Pediatric Surgical Association. So this isn't something that we kind of came up with on our own. So what does a subtract potentially offer you? Additional operative case requirements specific to your discipline. So if you're going to be doing pediatric surgery, it's going to be pediatric specific cases in addition to the case volumes that are required as part of the acute care surgery fellowship. Where appropriate, we add additional ICU exposure or other particular rotations that you need to kind of get comfortable in this subtract region. There's additional didactic content pertinent to this. We're incorporating, at least for the pediatric surgery side of the house, some subtract oriented meet the mentor sessions so that you can interact with some of the leaders in that part of the field. Networking and mentoring opportunities in the subtract. And again, I can't stress how important it is that it's a collaboration with the accrediting body for this sub-discipline, so that when you go to your hospital and you're seeking privileges, or you want to become involved in something, that you will, in theory, since it's a new program, be supported by that society as well, and they'll understand what this special expertise means. So this is where we are in the subtract discussion. Pediatric surgery, it's been approved by APSA, and by the AAST Board of Managers, so we're ready to launch within the next 8 weeks. We've been talking about a burn subtract. You can see here that we've done the conceptualizing and the planning, and we're just working on the final approvers from the American Burn Association. Been talking about some international rotations. We're kind of working on the planning phase now. Geriatric palliative care is just about to get started in the conceptualizing phase. But I will tell you that vascular surgery, I didn't put it up here because I didn't think about it at the time, minimally invasive robotics, those are the two kind of things that gave us the idea to do this in the beginning. They're a little bit more politically sensitive. And so we started with some other areas first to kind of work out the template. But I do think that vascular surgery in particular related to trauma is really important and would be the ultimate goal in some of these subtracts. And so what would theoretical vascular subtract look like? Well, we would expand the operative case volumes to include more endovascular angiography stents, things that you might do acutely in the middle of the night for a trauma patient. Maybe give you exposure to some ruptured AAA, so you get to get the exposure with all the bleeding like you do with your trauma cases. Fem de floors, non-anatomic bypasses, the use of various conduits that maybe you're not as familiar with, and importantly, some of the post-operative follow-up algorithms. This is all TBD. This is just me kind of theorizing off the cuff, but again, we would want to work with vascular surgery to develop this. Didactic curriculum would focus on some vascular surgery texts, additional modules within the acute care surgery fellowship, and hopefully exposure to some of the leaders in vascular surgery so that we can have some joint conferences and create some of those networking opportunities for our fellows. And then again, it's really important to get the Society for Vascular Surgery on board and to endorse this as well, so that we can design a curriculum that's really useful, but pertinent to the acute care surgeon. We're not trying to make vascular surgery fellows. This is not a vascular surgery fellowship. It's special expertise so that you're comfortable and you can go to your hospital and say that you have this extra training that's endorsed by both trauma and vascular surgery. So in the pipeline, more to come. Anybody who's interested, we're happy to take feedbacks. We haven't even entered the conceptualization phase yet, but just about to start there. And thank you guys for the opportunity to talk about this.
Thank you, Dr. Savage. You've done a lot of great work with the Acute Care Surgery Committee, and we're excited to see these upcoming changes being implemented. So next we have Dr. Brenner, who will be discussing implications for young faculty, strategies to maintain and acquire vascular skills. Dr. Brenner.
Thank you, Navpreet and Alex, for having me part of this great discussion. What I did was took the really great discussion points that you guys sent us and put them on slides. I'm sorry, my animation's not working, but really these are great focus points for the discussion that I'm sure we will have afterwards as well. So the first question was, what role is there for current AAST fellows or young faculty to obtain further training in vascular surgery? And Dr. Savage touched a little bit on that. The shock trauma model, I'm sure Dr. Scalea will discuss, really a novel model for training, not just residents and fellows that are within the institution, but also outside rotators as well. So electives during your surgical critical care year, those are certainly possible, especially it's a requirement for the ACS fellowship during that second year. There's rotations in vascular surgery. There's several issues with those, as they're obviously very variable. The case volume is variable. The experience that that residents and fellows will have during that is extremely variable. And depending on where they're training, obviously the case volume is going to be incredibly different. So that's a really varied experience for vascular trauma interested trainees. So additional fellowship training in vascular surgery, if you do not do a fellowship or in an integrated program, there are several institutions across the country that have non-ACGME approved fellowships, and those can be anywhere from 6 to 12 months. Those are at high volume vascular surgery institutions. So they may not even see trauma patients. So when you are a part of those, you really may not even get any vascular trauma experience whatsoever, but they are out there for those that are interested. There are obviously the ACGME approved fellowships at institutions across the country. Obviously, that is the only route that is currently available to be board certified in vascular surgery. So my own experience with pursuing a fellowship long ago, when Dr. Scalea and I sat down to try and figure out how we were going to do this, we talked a lot about, what would be required, where should I do it, where should I go? As a fellow at shock trauma, I did, 1 month elective in IR to try and get some experience. I was told that trauma surgeons will never be able to do their own vascular and endovascular surgery. So that was a great learning experience for me. After I finished my trauma fellowship, I did a 6-month endovascular fellowship at one of the non-ACGME approved fellowships. It was amazing. I did hundreds of cases in a very short time, but those were all vascular surgery. I had no exposure to vascular trauma. So not surprisingly, realizing that there's no shortcuts to the end result, which is board certification in vascular surgery, I did do an ACGME approved 2-year fellowship staying at University of Maryland. And that was a huge benefit because I was covering all the vascular trauma, shock trauma, obviously an incredibly high volume of cases. So that really just amplified my training in that particular field. So helping vascular, helping faculty have more experience with vascular trauma, that's obviously, it's different everywhere you go. Each institution has their own kind of pathway and algorithm, but, in the resuscitation area, when you get those patients in and they have these injuries, I think engaging trauma faculty in the diagnosis and decision-making and talking through, what does the CT scan show and what could it show, or what are you looking for? Kind of just talking through things out loud with them and having them be part of the decision-making process. So giving them, what are the options here? And, it's literally just vascular trauma training. Increasing the comfort level, I think, with these cases, a lot of it has to do with, oh my gosh, it's only something vascular surgery can do. But, the trauma surgeon is there, the only person there in the resuscitation. And in order to get these patients, through the system and to definitive hemorrhage control, trauma surgeons should be the ones taking them directly to the OR, even if it is a complex vascular case, right? We're the ones that can get proximal control. An example of obviously training for that is the AST course. It's a great opportunity to learn at least proximal control. So even if you're a trauma surgeon not trained in vascular, I think everybody should be able to take a patient to the OR, get proximal control, and then the rest, honestly, depends on the comfort level and such of the trauma surgeon and the consultant. So including vascular cases in conference is also something that we try and do a lot. It's great discussion. And I think the more you do, the more you talk about it, the less kind of daunting vascular trauma seems to some. Obtaining additional training at a high volume center. So again, that's more of the shock trauma volume, which will be discussed later. And then also getting trauma surgeons interested in researching QI projects with vascular surgery. So it's really just exposure and encouragement and education. How do we increase opportunities for faculty to engage with advanced vascular trauma management? So really all those things I mentioned above. And for those who are really interested in getting involved in associations, you may or may not know about the Endovascular Trauma Management Association and its own corresponding journal. Really, it's just focused, it's a real international group focused on really damage control, vascular, endovascular, and trauma management of patients. So what have I learned being able to teach trauma surgeons vascular skills? So that's a loaded question, but also a great one. So there's a huge variety of skill level that people come in with, right? Trauma surgeons, all of us have our own different, skill set based on, where we trained, where we did general surgery residency, where we did our specialty training. So there's really a huge variety, which I honestly didn't anticipate was so varied until I started teaching people from other institutions. So the resources also vary at other institutions. They may not be able to learn to do these procedures, and they may not have the support either from their bosses. We did learn a long time ago when we started teaching VEST that age, lack of experience in endovascular, and training background did actually not indicate any kind of educational issues. Just 1 second, sorry. So younger residents and faculty do have more experience now, thanks to the residency program. So I'm not just the integrated vascular surgery programs. Their graduates obviously have a tremendous amount of experience, but really just general surgery residents, based on their case volumes, even though sometimes they appear to be not a lot. When you watch them learn how to do things like Roboa or place lines, they really have a lot more experience, I can say anecdotally, than those from those who have trained without that. And again, the only requirement to learning is desire. So how can this be achieved? How can we get trauma surgeons comfortable with vascular skills? So partnering with vascular surgery and endovascular cases, or even interventional radiology, really getting familiar with the catheter and wire skills that are required. Utilizing industry. So industry is incredibly supportive, really at all levels, both with virtual and in-person training. They will come to your institution, they will help you out. Just remember that industry is not necessarily clinically based, so they'll be able to show you all the devices, the catheters, suggest how to use those. But ultimately, it's us as the trauma and vascular surgeons who will be deciding how and when to use those devices. Performance and or simulation is critical for skill sustainment. So in order to keep any skill, not just endovascular or vascular skills, simulation is critical. So both taking and teaching standardized training courses are really important. The last question was, how do we foster collaboration between trauma and vascular surgery divisions? I will say, without question, this is very institution and division dependent. So it varies across hospitals and institutions. So other ways, collaborating in peer review meetings and M&M cases and research projects with them, implementing clinical service protocols together. So, sitting down at a table and saying, hey, we're going to think about doing Roboa in some of these patients. What are we going to do when the extremity compartment syndrome comes in? Who's going to take care of that? Mesenteric ischemia with the acute care surgery, protocols. So sitting down together and getting to know them, coming up with clinical algorithms really helps a tremendous amount. Inviting them to review vascular trauma manuscripts. If any of you are on editorial boards, that is also a great way to engage trauma surgeons and get them on board with the vascular literature. Ask them to participate at association meetings if you have the ability to do that. Offer to give educational sessions to trainees on vascular trauma, both trauma trainees and vascular trainees. Invite fellows and young faculty, which I do all the time, to become best course instructors, not just trauma fellows and faculty, but also the vascular surgery integrated residents and fellows. Discussing, in the clinical setting, discussing the SICU patients that you take care of that are vascular surgery patients, and talking directly to the faculty. We do, run into the habit of communicating sometimes through the trainees, but especially if you're a trauma surgeon in the ICU taking care of a vascular surgery patient, get to know that attending. It makes a big difference, when you're calling someone at 2 a.m. that or you've had a conversation with, rather than some complete stranger who you've never met before. So just get to know them, obviously as people and peers. So my last thought, which I'll just throw out there and I'm sure we'll discuss a little bit about, but it's not just about learning the technical skills. It's not just taking a trauma surgeon and saying, okay, we're going to teach you how to do this and that. It really is, it's a 360 comprehensive approach, right? It's about the resources that you have to take care of patients. So what does that include? Consulting, diagnosing, managing, taking the patient to the operating room if that is required. That also includes covering the service that you're responsible for at the time. So if you're covering trauma and emergency general surgery, you're going to be in the operating room for 5 hours doing a vascular trauma case. Who's going to be responsible for the service and the incoming critical traumas while you're there? Obviously, short and long-term postoperative care and surveillance of these patients is critical. So it really requires more than just, how are we going to teach these people, these trauma trainees the skills, but it's about partnership, time, availability, and having supportive partners in your own group. So thank you so much.
That was great. Thank you so much, Dr. Brenner. I feel like I should pay you $5 right before you started. My fellow was texting me, do you think they'll answer the question about where I can get additional training? And I was like, just you wait. Finally, for the programmatic part, before we move into discussion, Dr. Scalea is going to discuss the shock trauma model and how shock trauma delivers vascular care and trauma care in Maryland. Dr. Scalea.
Did I manage to get my slides up? Yes?
You did, sir. They look great.
That's this is the first and only time I will do this unsupervised. Well, Alex and Navpreet, I appreciate the opportunity to end this with some, at least some thoughts about how we have looked at this. I have looked at this over 40 years of a career, and some thoughts about where I see this going. Well, the title of the talk was A System of Care, and so I asked myself, what does that exactly mean? So I spent about an hour just roaming the internet, and I came up with these sorts of thoughts. It's interdisciplinary, interagency, as they said, collaboration, individualized strength-based practice, and accountability. I have said forever that we have to submit our results to peer review, and if we can't do it as well as the other people, then we shouldn't be doing it. Now, there needs to be sufficient volume to justify resource expenditures. As Megan said, if you're going to tackle a big operative case, then you got to have somebody else around to do the other stuff. And I think we have always believed that you needed to have people that were interested in questioning the status quo. Just because that's the way it's been doesn't mean that that's the way it should be. And we do it our way because we believe that this is optimal care for all of the patients, including the patients with vascular injury. Now, one of the things was what impediments did I meet when I did this? I met none, because I am functionally the CEO of the hospital. We made a decision. I said, this is the way it's going to be. But I did it with the Division of Vascular Surgery. I sat down with Raj. I said, you got 10 surgeons, and I'm not interested in everybody taking call, twice a month. I'm just not interested in that. Some of your guys like it. Most of the vascular surgeons will do it if we make them, but would prefer not to. So I said, we're going to do this with people that really want to be here, because we want to push the status quo. We want to be innovative in this area, and we have been. Now, our service is set up with 2 general surgeons, me and Deb, and 1 cardiac surgeon, Jim O'Connor, with years of experience, and we cover trauma, general surgery trauma, thoracic trauma, and vascular. I was thinking back when I was a chief resident in the Stone Ages, I did 50 open aortas, which would be, more than an institutional practice these days. But that's what we did. And I wasn't the only one. And so we accrued a huge amount of experience during training. And when I went to Brooklyn, There was nobody around. There was no vascular surgeon that wanted to do any of this. And so we did this. And we always have one person on call capable of doing endovascular stuff, and we overlap the schedules. So we build redundancy for the night that poor Rishi was over doing a subclavian on the university side. We need to have enough people to go around. That's what the schedule looks like. We got thoracic call, we got vascular call, we got endovascular call, we got somebody making that is the weekly attending to round on the vascular patients, and we hand off. There's always extra people to help out for when it gets really busy. Now, those two people who most of you have never heard of are Jerry Shafton and Sal Scalfani. My partners, and Jerry was my hero and my mentor. And he was the one that taught me that there was no such thing as a stupid question, that every idea got its day in court. And we have really used that as our kind of moral compass as we have made this happen. How did we get there? Well, this is a 2015 paper from our institution presented at the AAST. And the results were frankly awful. And people in the group said, this is embarrassing. We can't publish this. And I said, this is embarrassing. That's exactly why we have to publish this. Because if it's this embarrassing here, I got news for you, it's embarrassing a lot of places. And this is not okay. 80% of deaths were attributed to early uncontrolled hemorrhage. Now, this is a slide Megan sent me, and I realized that the interventional radiology suite was 1.5 city blocks from where the resuscitation unit was. And there was nothing quite as lonely as being over in the IR suite at 3 a.m. with some poor guy that was really bleeding from his pelvis, or somebody we were using catheter techniques for damage control. That was not okay. We built a new tower in about 2016, and I did some horse trading, and I traded the chief of cardiac surgery one of our big open rooms for the hybrid room. He thought I was the dumbest person on earth. They had this hybrid room. All they ever did was break the damn thing because they didn't really use it and they didn't want to use it. So they would keep breaking the C-arm. And I told the administration we'd save them money because they wouldn't have to keep repairing it. And so we got the hybrid room. The first thing I did was I called the interventional radiologist and said, this is great news. We now have a resource here. It's the same equipment you guys use. So you can come over here. We will have it set up. All you got to do is walk in and do the case. And they said, you know what? We're not coming. And I said, that's okay. We're not calling. And that was the last time we called interventional radiology for a catheter therapy for a vascular problem. We initiated a 2-person catheter hemostasis team. We had combined skills. This was the 2016 proof of concept paper that we wrote with Megan, of course, as first author. We proved we could do it. We proved it was effective. And we proved that we could do this with no procedural complications. As this then morphed, this is the American Surgical paper that demonstrated we increased case volume. When we had people that wanted to do cases, guess what? We did more cases. When we called IR and there were 50 reasons why they didn't want to do the case, we did fewer cases. And we cut the time substantially. We took time down about 2 hours in the pelvis, just over 2 hours in the liver, and 2 hours in the extremity. We did not alter time for the spleen because if you're unstable, you don't get a catheter therapy for a splenic injury. Now, the service continued to evolve, and we took inventory, and this was Joe Harold's work presented at the Western Trauma, where he said, how, if you came and did a year of every other night call, or we had a 6-month concentrated volume here, how would you stack up, at least for the case volumes necessary to sit for the certifying exams for interventional radiology and vascular surgery? And it turned out we met the numbers, not all the numbers, but we were well in the range of providing enough procedural experience to do what the other services, the other subspecialties say is necessary to become competent. And you can see our volume just grows, right? Every year, this is even 2018. I'll ask Rishi to comment later on current volumes. The numbers just kept getting bigger. The more we had a resource, the more ways we learned to use it, the more cases we did, I think the better we got. And I'm the guy that's sort of the conductor here, but in my old age, I've gotten smart enough to find really good people and say, just go. And that's Megan and Melanie Hain. They were the first iteration of our endovascular trauma service. That's Johnny, Rishi, me, and Joe DeBose. That was the second iteration of the trauma endovascular service. And now it's Rishi, Yvonne Chung, Chuck Fox, Anna, and me as the current iteration. And each iteration continues to increase the level of sophistication of at least of the questions that we try to ask and answer. Now, this is, as far as I can tell, a complete list of people that have done formal vascular training with critical care and general surgery. It's sort of the triple threats. It's 15 or so people. I don't think I missed anybody. Maybe there's another 1 or 2 that have come out recently. And so these are the people, I think, that script the future. These are the people that will ferry this project along and get us to where it is we need to be. And I'm very proud to say that of them, all but 5 are ours. Either we trained or worked here and then went elsewhere. So there's a certain amount of preaching the shock trauma gospel that is going on as people go out and set up their own programs. And what's the problem? The problem is that we fight about all the wrong stuff, right? We fight about who owns the case. We fight about who's going to hold the wire. We fight about who's going to get paid. We ignore the patient and the need to deliver care in the system. Leaders in our own field badmouth stuff without any knowledge or experience. And the flip is true, where people become self-proclaimed experts with 0 experience. It's nuts. We fail to have societal or institutional commitment. We find 1,000 ways to get to know, and that's not going to work. This happens in our shop about 8 times a year. This is just the most recent one. 45-year-old guy got hit by a car. He had a popliteal injury and a tibial plateau fracture with a cold foot. He was at a designated trauma center with a board-certified vascular surgeon and a board-certified orthopedic surgeon who refused to operate on him because they weren't comfortable. We stepped on the accelerator. He got here 4.5 hours after his injury, and me, the non-vascular surgeon, did his popliteal artery and reperfused him, but it was too late. His muscle was 80% dead. And this young guy ends up with an above-knee amputation. That's not okay. So I think that trauma is a disease and vascular trauma is a subset of the disease of trauma. It's not only about repairing the damaged blood vessel, it's about a complete plan. And having one surgeon that is facile with the technical skills and overall knowledge, to me, is the ideal way to do that. And while our system isn't feasible everywhere, I get tired of people saying, well, you can do it because you're shock trauma. Take the principles, apply them to your own institution, and make it better. Now, our direction is we have 8 surgical fellows. Right now, we have 4 AAST approved second-year slots and 4 that only do 1. And we're going to convert the fellowship to 8 surgeons, all of whom stay 2 years. We will keep going with our 4 in the acute care surgery year, unless you want to bump us up 1 or 2, Stephanie. We certainly have the volume. But I get about 8 requests a year from surgeons that say, can I come spend 6 months with you and do vascular and endovascular? And right now we say no, but we don't want to say no anymore. Of our 16 fellows from first-year fellows last year and the ones that are coming, 1 did minimally invasive for 8 years and then come and trained with us. 2 are doing the our fellowship as a bridge to a minimally invasive fellowship. This is the future. And so we want to offer opportunity. We have surgeons that are very interested in cardiac support devices. And so somewhere in there, I see this going forward. We would love to be the demonstration project for the AAST. This is me with my hand up. Please pick us. And I think this is very similar to 1997. In 1997, we started training emergency physicians in critical care, and people called us names. They'll never be able to do it. Everybody said they're going to be unemployable and would never be board eligible. Not one of them had any trouble getting a job. And now they're board eligible. And this is similar. I'm not going to be around to see the final version, but I'm convinced that it'll happen. And I only hope that together we can move this principle forward, because it's what the patients need. It's what the trainees need. It's what the trauma system needs. This should only be how, not if. There's my spiel.
Thank you, Dr. Scalea. I think you may have to unshare your slides
I'm trying to.
all the way up. There, perfect. Thank you. You always deliver. So we're going to shift gears a little bit. We're going to kind of go into our Q&A, but it's not going to be a typical Q&A. So for those that don't know, BOSS Conference is a time-honored tradition at Shock Trauma. It's a conference moderated by Dr. Scalea, who we all affectionately call BOSS. This is a weekly case conference, which generates a lot of great, thoughtful discourse. This is our way of bringing shock trauma to the AAST community. Now, feel free to make comments and questions in the chat function, and we will try our best to incorporate them within our own discussion. So, Dr. Scalea, I give you
And given the shrinking personalities of the panelists, I am hopeful that you guys will interrupt, ask, articulate, jump in, because that's when these discussions are the best. And we'll start with Alex and Navpreet as the people that are representing, at least, the trainees. What do you think young surgeons want? How do they want it to look? What would be ideal for you guys that are finishing training or new in your career? What do you want?
I'm happy to jump on that grenade first, having not gotten the regular BOSS conference exposure. I did 2 years at Denver with Chuck Fox when he was there, Mel Hain when she was there. And I was talking before you came on, Dr. Scalea, when we were sort of, checking our slides and chit-chatting. that Denver was a little bit interesting because it is a really unusual model. There just isn't the same sort of ultra structure that most academic medical centers or most county hospitals. I work at a county hospital with a whole division of vascular surgery. Denver was a little bit weird. And for me as a young faculty member, I feel like I've had sort of a pastiche of different models and a pastiche of different philosophies. I was telling Dr. Brenner that I have to go up the road and take the best course because I still haven't taken it. Don't tell, not that this is being recorded. I think I'm really lucky. I work at a busy place. I work with Brant Putnam and Molly Dean, who are Shock alums. We have a culture of sort of, as you said it, we want to do right by our patients. If I or we are the right folks to do that, awesome. If we get our vascular colleagues involved, awesome. I do think that there really is a lack of recognition of trauma as a disease, particularly among my contemporaries who are either fellowship or integrated trained. As Rishi was talking about in his talk, for me, I want to do things safely and I want to see a little bit more, and I want to have some senior mentorship of folks who really feel comfortable owning the lesion, owning the patient, owning the disease, owning the resuscitation. I can do some stuff, but I'm young enough that I need to get some more tricks up my sleeves.
Navpreet?
I think in Dr. Scalea, we've kind of spoke about this a little bit before as well too. I think one of the problems is that, acute care surgery is a great field. There's a lot to it, but I think sometimes when we are kind of being raised in these academic centers, we kind of don't have much command within a certain specialty, and that gets lost. So I think that's one of the biggest things. It's hard to kind of say what exactly that is, and I think that is a little bit different for every single person. But I think once you kind of associate yourself within this field, you're generally kind of second to some sort of consultant. And I think what we really want is that command to a certain discipline, whatever it is.
Rishi, Stephanie, Megan, how many are enough? How many of whatevers, if you come out of a good residency program, how many vascular cases or endo cases, or what do you need to be competent at this?
I think, unfortunately, it's not simply what you do in fellowship. In vascular surgery, when you come out of fellowship, no matter how good that program is, every case you do as a young attending is going to have one of your more senior experienced people looking over you. The learning curve absolutely does not stop with fellowship. And so I think for this really to thrive, what you need is not just the training, but you need a division where there is someone who knows how to do this, who says, okay, I'm going to mentor the young trauma surgeons who are going to do these repairs. Like, I'm really happy. Like last week, we had Malika and Mira did an innominate repair with me. My hope is one day that I won't get called in to do that kind of thing because they know how. But the only way that happens is not just with fellowship training, but with active collaborative mentorship as attendings. And that means that vascular attendings have to be willing to work with trauma attendings.
I think it's tough. It depends on the environment you're in. There are some institutions I've practiced at where the expectation was that as the trauma surgeon, you would do this, and so that you had the support of your division and the hospital, and that's how you cared for the patients. So you took care of them when they came in. And there's other places I've been where it's a very political issue. And so not only do the junior faculty have the anxiety of having to deal with what's potentially a tough injury and the technical aspects of it, but also a lot of people that may not be in your lane providing feedback on how you're performing. And so kind of to Rishi's point, you get the skill sets in your training. Those continue to grow as a faculty member when you're presented with new challenges and having to make these decisions, but also knowing that you have the top cover in terms of someone to help you technically or with the decision making, but also to back you up so that you're confident in pushing yourself a little bit. And you know that, if you're trying something that's in your skill set, but kind of at the edge, that you're not going to get shot down at M&M or get a lot of flack from the leadership because you did something that you absolutely should be able to do.
Megan?
Yeah, I don't know what the magic number is for each, for each case. I do feel very strongly, and as painful as doing a 2-year vascular fellowship is, there is, something to be said about the experience that you get, not just doing those whatever number of cases, but the 2 years that you're learning the entire disease process, and everything that goes with that. So, a number is one thing, but the whole package is the other. And honestly, that's obviously how anyone is able to sit for the boards. It's not just the numbers, it's also the experience and the length of time of training. But on the flip side, when you go to an institution and you say, look, I've done as many of these as someone who is board certified, unless you have that piece of paper, it's an uphill battle in the credentialing department. So I think, we have a lot of work to do to make people aware that, maybe you don't need to do, an entire formal fellowship to get trained. But as you mentioned, it's a work in progress.
Now, clearly, and I think this has been driven by vascular surgeons, much more and more and more is being done with a catheter, and less and less is being done open. There's the Memphis group that said pretty soon axillary and subclavian artery injuries are all going to be treated endovascularly. We have not ascribed to that. Rishi and I just did an axillary artery open. It was a very straightforward case. But the more endovascularly oriented the care becomes, the more you need to have somebody who has real endovascular skills, and that's going to be, at least as far as I can tell, vascular surgeons. Is that going to happen? Is that the right answer, that everything is done with the catheter, or almost everything? Where's that break?
I don't think there's ever going to be a world in which an open repair of some, vascular injury is not going to be needed. Just like, we could stick a laparoscope in every abdomen, but that doesn't mean the XLAP is going to go anywhere. So I think, comfort and ability to perform open vascular repairs, that's something that I can't see it ever going away. The caveat to that is, just because you know how to use a catheter and a wire doesn't mean you should in every scenario and every vascular injury. And part of that comes with training and experience and knowing, which toolkit to open when it comes time.
Rishi, Stephanie, other thoughts?
I mean, I'm kind of the opposite. I wish I had more endovascular skills, because I think that my skill set's primarily open. And so the kinds of experiences that Megan references in her fellowship, I would love to be able to have to augment my decision-making, but I don't think open is going to go away. There's just, sometimes you can't even help it when something gets blown to shreds. So I think being able to pivot one way or the other is really important.
We have maybe 4 or 5 times a year, we get a patient transferred in that had a popliteal artery stented by a board certified vascular surgeon. And then we go take the stent out and do the bypass. I maybe that was their idea of damage control. I don't really know.
I think that one of the things that needs to be reconciled between vascular and trauma surgery is the scope of time that we're interested in. Vascular measures its outcomes in 1-year, 5-year patencies. Almost all the trauma vascular literature I've looked at looks at a month out. Now, part of that is because follow-up for trauma is terrible. But I think that it also speaks to, or that also informs my opinion of endovascular trauma care, which is, in a 25-year-old, I am no longer super enthusiastic about putting a stent in and relying on that 25-year-old to do dual antiplatelet therapy or take monotherapy for the remainder of their life. I am a lot more confident that if I do an open repair, hopefully use vein, and they don't have to take anything, and they don't have to think about it again, then I feel a lot better about that. Even if it's a more involved surgery, even if it's a little more morbid for the recovery, the difference being axillosubclavian. But even that, as I get older, the appeal of open is growing in my mind. It just seems more durable, and you're relying on the patient's compliance less.
I think the other reason,
Go ahead.
I think the other reason we're seeing these popliteal stents, and we're going to keep seeing them more and more, is because that's what they're being trained in. They're much more comfortable, especially the young faculty. They are so much more comfortable putting stents in, and eventually it's going to get to the point, and to be honest, it already sometimes has, is that they're calling trauma with help with the open surgery. So we're still going to be, we're still the ones that can do open and endo. I fear that their training pathways are we're just gonna end up having popliteal stents like crazy.
It's interesting. I feel like you all are such a great panel, but perhaps the one thing that we overlooked is that it would be really interesting, Dr. Scalea, if you asked the question that you asked to me and Navpreet of a contemporary of ours, what they want as young vascular faculty who might be either take trauma call or work at a trauma center. Because I agree with Dr. Brenner, when I was at New York, prior to coming back to Harbor, we had some great vascular surgeons who were really, really good at elective vascular surgery and taking care of, chronically ill people. And I had partners who the vascular consultant, also as a young person taking trauma call in New York, they're calling for vascular help, and then they need that first responder needs to call a second responder because they're not comfortable doing open vascular surgery in a trauma patient. And I think, Rishi, I really liked your Venn diagram about sort of like who's winning what part of the Venn diagram, but it is interesting, this idea of like, we need to work on getting us back together. We're drifting apart. And then as someone, it's hard for me to call you Stephanie on the thing, Dr. Savage. Dr. Savage and I are the non-shock invitees to this ball game. And so you all do have a really unique setup. And I'm not saying that, Dr. Scalea, to say that's the only place that can be how it is, but it's hard, I think, if you don't have as deep a bench and you don't have as many folks with the interest or the skill or the variety of training paradigms that you can call on for help or mentorship, because you have to really play nice in the sandbox, whether it's about money or politics or prestige or just everybody's tired and overworked. It gets really tricky to sort of figure out kind of what's the best, safest, most reasonable thing to do. I can't really comment on a popliteal stent, but I can't help but think about this idea of like, yes, a young person's compliance is questionable, but is it perhaps becoming I don't want to say standard of care because that's a loaded term, but this idea of an endovascular attempt at an axillosubclavian or another injury complex? Is it the case that that either we should be doing endo when we don't have that resource or vice versa for certain injury complexes? And I don't feel like I'm sage enough or old enough to sort of speak intelligently about that, but I'm wondering about, should we be thinking about like maybe only doing open SFAs and only doing endovascular subclavians? Because there is some morbidity of getting there in my hands. If I get there open, I'm going to cause some morbidity.
I mean, Alex, there are axillosubclavian injuries that should not be fixed endo, right?
Yeah.
I don't think that saying, oh, this is the kind of thing that you need an endovascular approach, I think that doesn't benefit anybody. One of the things that when we have trauma fellows rotate through the endovascular service, I don't expect them to leave, being super facile, doing everything endo. The important thing to me is I want them to look at an injury and be able to say, yes, I think this is something that can be addressed endovascularly. Let me call the right person, right? And as for getting vascular surgeons who are interested in trauma, it's a little contagious. I mean, remember, both me and Mel started out the same way, which is we started as just some of the vascular surgeons on faculty who, got called over on Pig's side when they needed someone. And I may be speaking for Melanie out of turn, but for me, certainly it didn't take long before I realized that in order to really be good at this, I needed more training. I needed to understand trauma more. And I keep coming back to, if you really want to do this, and maybe dual training may be the only way to really do it well, because both fields are enormously complex, both technically and physiologically.
It's unfortunate that Dr. Savage had to step off, because along with this idea of specialization within the confines of the AAST 2-year fellowship, is it the kind of thing where we need a 3-year combined fellowship? Now, I'll say that I love Dr. Haynes. She was great. And you seem great. We're meeting for the first time on Zoom, but I think you guys are
I'm
not
great.
He's
the
not
rule.
that good. He's
No,
not.
I'm fantastic. Don't listen to him.
You came across my TikTok For You page a couple of weeks ago, and I'm sure the algorithm is listening. But you and Mel are the exception, not the rule. And that we have great vascular colleagues across the spectrum, but truly, and you as a vascular surgeon, you tell me I'm wrong, most people who go into vascular surgery are not interested in taking care of critically ill folks. They want to take care of chronically ill folks. They want to try to make chronically ill people temporarily better, if I'm being the pessimist that I am, fem to floor, fem pop, fem chop. But most vascular surgeons don't want to work in the ICU. Most vascular surgeons don't want to take trauma call. And I think it's great that you and your interesting cadre of 15 or 20 of you, and Chris Krabari and Megan Brenner and Mel Hain and Chuck Fox exist, but you guys you're not the rule, you're the exception.
But Alex, look at the opposite. Once a week, if not more, I get an email, a call, or I get taken aside by a resident who says, I want to do trauma, but I'm really interested in doing vascular trauma. You're right. I think most vascular surgeons don't want to do trauma. Yeah. I think there's an enormous proportion of people who want to do trauma surgery that are open to doing vascular training.
Yeah, and part of my strong feeling about this is Chris DiVirgilio, who's now my chair, when he was my PD and I was a resident, was like, you're going to do vascular first and then trauma, right? And I was like, no, I can't do 4 years of fellowship. I need to pay my bills. So I'm wondering if there's a hybrid model or a role for getting some sort of 3-year, I'm making these numbers up, you only need a year of crit care. I really think there's value in the second year of the AAST experience. There's a really intentionality to that curriculum. And I just wonder, can we do 18 months of each and call it square? And it's 1 more year on top of general surgery. And then you really have a really broad and really deep toolbox to take care of these patients.
But whatever you do, you have to get the institution where you go and work to buy into that. And that is not, when you're in the ivory tower, it's one thing, but when you step out of it, it is a different animal. And that's where the rubber meets the road. Is, are you going to be able to go into these hospitals and be able to do all of the things that you spent 1.5 years or 2 or 3 years training doing?
Everything comes down to credentialing, right? And credentialing comes down to board certification, and board certification comes down to the ABS. And so maybe the first step in this is just getting vascular and trauma surgeons to maybe play nice.
Actually, credentialing is a local hospital. It's a local hospital responsibility. The hospital can set its credentials any way it wants to. So if the hospital says you must be board certified to touch in vascular surgery, to touch a blood vessel, then you're kind of shit out of luck unless you've got vascular boards. But it doesn't have to be that way.
But most of them are like that, boss, right? Because they're the ones that have to take the responsibility at the end of the day and say, well, we credentialed this person who's not board certified, even though we have a division full of board certified people. So I feel like they're CYAing a little bit.
That's mostly driven by the vascular surgeons who wish to protect their, it's true, right? I mean, this was true in critical care.
Yeah.
Right? The pulmonary guys would go to the credentialing board and say, that person isn't fellowship trained. They don't have boards. They shouldn't be allowed to touch their own patient in the ICU. It was about turf.
How do we get those hospitals or those places? Because I don't know if this is oversharing. I have very, very liberal credentials here at Harbor. Basically, Brant Putnam said, check all the boxes. And I said, sir, I don't do gynecologic surgery. He's like, check all the boxes.
That's my.
And I did it,
boy,
right?
You're-
Because
you're-
Alex,
you're
that just
in-
means
you're
you
in
can be
mini
on
shock
more and more
trauma,
call
Alex.
schedules.
But that's unique to how we work here in the county. In the same way that you all, whether you were or are at Shock, work very uniquely to some degree too. How do we show, is it research? Dr. Scalea, you were talking about this idea of really participating wholeheartedly in peer review and sharing your good results. And you shared that paper that we talk about that paper from 2015 at Harbor at least once a month on our multi-system trauma operations committee meeting, talking about trying to get that 60-minute door to radial artery stick time for our IR responses. How do we share our bad results and good? Does this need a blue ribbon commission? How do we, because it does feel like there's a looming problem, as people retire and step away, and as Navpreet and my generation go from assistant to associate to full, I worry that we're not going to maintain some sort of semblance of the bench that we have now, that people who came up in an era when there wasn't as much specialization and there was high volume, like you, sir, Dr. Scalea, like when you were at Kings County, you were just doing it all, and that just isn't really a thing most places anymore. I pose this to any and all of you. What should we as young people be doing to take up this charge?
What you think, Megan?
I think so. We need to, of course, publish, right? The more information that's out there, it gives leverage for the champion at whatever hospital who is trying to do this and coming up against walls left and right. It gives them something to say, hey, look, this is possible. This is what's required. And, I think getting the word out there is probably the biggest help in terms of that. Also, finding friends where you possibly can is another way to do it in an institution. Usually there's hopefully one vascular surgeon in a group who might be willing to, help go to bat with you and say, look, I'll proctor the first 5 or 10 cases and I will, present my outcomes. And if anyone feels any differently that I can't do it as well as this group, then, and kind of go that direction just as an option.
We're lucky here that we have good relationships with all 5 of our vascular surgeons, and we're a trauma hospital in a way, as a safety net county hospital for South Los Angeles. And so you can't be a vascular surgeon here and not take care of trauma patients. But I just wonder, and I think those are great answers and great suggestions about sort of being an advocate, sharing everything, and then sort of trying to work on building bridges. And I very rudely cut off Dr. Dhillon, my boss. My mini boss.
Thanks, Alex. So Dr. Brenner, you had mentioned getting involved in something like EVTM. I know Dr. Kundi is involved with SVS pretty well. So I think one of the problems we run into, we talk about local environments, trauma surgeons, vascular surgeons working together, more from like a broader big picture view. How do these societies collaborate with each other? What's the low-hanging fruit?
Yeah, not well is the answer, which is why I mentioned, those of us that are able to, invite vascular surgeons to talk at our meetings and vice versa, getting that conversation started helps a lot. There is definitely and again, this is very institution dependent, so I don't want to make generic statements, but, there's a whole spectrum of different types of relationships and preconceived notions about trauma surgeons from a vascular perspective. But, there are some associations that do have formal relationships. The college has an SVS representative, which with the Committee on Trauma. So we're helpful and hopeful that will maybe lead to some collaboration with the SVS. But, again, it's really just, collaboration and getting the word out about what we're trying to achieve. And also on the flip side, we've been talking about how to train trauma surgeons. we're responsible for training vascular fellows too, right? These are the people that are going to go out into the world and get called for trauma injury, for injured patients. So it's our responsibility for those of us that have the skills to be teaching the vascular fellows. So I always invite them to everything I possibly can. Become a best course instructor, come to the meetings, publish, let's do research, because the more they're exposed to, the better outcomes hopefully they will have it with their trauma patients moving forward. Even if they don't want to take trauma call, the chances are pretty good if whatever institution they end up at, they will be taking care of trauma patients.
I think that the societal interest on the SVS side in trauma has been growing steadily. For the last 2 years, I've run an afternoon session on vascular trauma at the Vascular annual meeting. And before that, the idea of dedicating an afternoon to trauma would have been kind of ludicrous. So I think that there is increasing interest, and I think it's grassroots. I don't think that it's something that's being, dictated by leadership. I think it's something that your average vascular surgeon, maybe because they are being consulted more and more, is interested in learning more about.
We have gone 20 minutes over time.
It looks
There was
like
not one virtual punch thrown, Dr. Scalea. I got to say, I'm a little bit disappointed, but maybe
me
we didn't
too.
invite enough dissenters.
Because Dr. Kundi and Dr. Brenner are so intimidating.
Yeah.
We haven't opened the chat, that's why.
I think a couple of question and answer from our attendees were answered by Dr. Savage, Dr. Kundi, but just for people who aren't following along, there were some questions about kind of how do you get dedicated rotations to practice skills, comparable to FLS and FES, good models for simulation. We talked about the best course, and we've talked about opportunities to scrub in and rotate and sort of put yourself out there sort of for the actual wet lab of life. And then there was a question about a lot of discussion of politics being a potential barrier to trauma surgeons training in the specific aspects they want to improve on, whether that's vascular, IR, MIS, as discussed today. How does someone applying for a trauma quick care fellowship ask the right questions? And Dr. Savage responded to that by basically saying, get the opinion of the people who are actively training there and not just the faculty, as well as the residents at the institution that you may be joining, which I think is really good advice in all things: job, fellowship, residency, maybe even medical school. Are there any last controversial, contentious things that we should bring up right as we say goodbye?
It's been great. I really kudos to Navpreet and Alex for putting this together, and it's an important topic, and it's about vascular trauma, but it's going to be about all sorts of other things as we go forward, about carving out how it is we're going to continue to evolve the practice of injury care and do things better as we go forward. We need more and more tools in order to evolve the practice.
Absolutely. Thank you all so much for your perspectives. I know that Navpreet is going to share a couple of statements from the AAST as we sign off, but thank you all very much for joining us. I really appreciate it.